Hello, I'm Dr. Esther Park. I'm a child, adolescent, and adult psychiatrist. Um, so the age range of my clients have been age 5 all the way to like 80. So I have seen the entire developmental spectrum span of my clients, and I'm very privileged to be here again at this church and also serving the VAY um, for a few years. So thank you for this invitation again. Um, the mental health crisis intervention is a huge, important topic, especially because right when a crisis is happening is when the most panic is happening. And so before any of that, hopefully it will never even happen in front of you or to you, but you might invariably meet another family that might go through this. And then you would be of great help to equip them with whatever you learn today. So even if I hope you will never have to go through what these slides are going to talk about, but you might meet somebody and then you will feel equipped to help your friend or your family member or relative. So um, the harmful behaviors and suicidal behaviors are on the rise for young people. This generation right now, it is the highest rate than any other previous generation, to the point where ages 10 to 24, that age group is suicide is the second leading cause or second cause of death, which is preventable. And it's just horrible that that's happening even as young as 8 to 10. They're thinking about it, maybe even with the advent of social media and all of these ideas that are spreading. But it's not just because of that. The rise of mental health issues in the young is on the rise, and that's why the result is these kind of mental health crises and suicidal behaviors. So we're going to be a little bit more equipped today. How do you know someone needs that immediate help? How do you know when to refer um, for therapy or medication management to be able to prevent even those things? So today's agenda includes what will distinguish the expected, pardon me, it's not advancing. Why it's not advancing? Okay, so I know it's small, so I'm going to read it. What distinguishes the expected ups and downs of mental illness from a crisis? Because all children and teens, they'll have ups and downs. We all have ups and downs. So what's the difference between that and then we can call it a crisis? Why must we be prepared to know the warning signs and also to act swiftly upon that first sign of crisis? What are some examples of behaviors and comments that warrant action to intervene? And how can we support someone in the middle of a crisis? And what is what if someone is suicidal but there's no active gesture, intent, or plan? That's one of the most iffy time of what to do. And then we'll talk about some resources. Now, what distinguishes the ups and downs of a mental illness from a crisis? So, the definition of a crisis is imminent or already engaged behaviors that are potentially dangerous to themselves, to others, or even to property. Because sometimes they will want to destroy property. That's a crisis as well. So it's imminent, meaning it is about to happen. It could happen right now. You don't know if you walk away if that person is going to be safe or not. And it is not a surprise that whoever has a poorly treated or untreated depression, they can experience um, sedation, lethargy, and low motivation. But when somebody becomes suicidal because of their depression, and they have a plan or they have intent to hurt themselves, then the depressive condition has led to a level of crisis that requires immediate attention. And we'll talk about that a little bit more in detail. And why must we be prepared to know the warning signs? Okay? So the first reason is the potential lethality of a mental health crisis is real. Lethality of how it can even take someone's life. Once, if their life is gone, it's too late, right? So we want to try to um, know about it and intervene right away. And as a matter of fact, I helped intervene one of my clients the other week, and trying not to make her go to the hospital. It was like a very difficult situation. But then she herself one day felt, I need to go now. Right? So sometimes the client will work with you to realize the potential lethality. The second reason is that the completed suicide rates have risen amongst the youth and young adults and individual with suicidal ideations. There are more and more who think about it. And that's the first step, right? To think about it. And then the next is having ideas, imagery, and then the what if. And then the last level is intent, meaning they start to create the plans and then they start thinking about how they'll do it. They'll start convincing them that that is the best thing I can do, and because it's not worth living anymore. And then the plans and intents, right, can be addressed to prevent the attempt. Because once it gets to that level, that third level, we have to be aware that that's going on so that we can prevent that attempt. We can intervene. I hope we can always intervene from the beginning when they're having the thoughts. But many families have gone through people sharing the thoughts, but it doesn't seem very um, serious, so they don't really intervene then. Or it happens, many teens utilize, I want to kill myself or I don't want to live anymore, to be manipulative. And so many parents ask, how do you know the difference? Because I don't want to be manipulated, by those kind of words. So we'll talk about that as well. So this next slide is about how can we know what are the behaviors and comments that warrant action to intervene the progress toward danger. So the three is talk, behavior, and mood. So we'll talk about the first one, which is talk. What a person says can be important as an indicator of suicidal ideations. So if they say anything about killing themselves or feeling hopeless, being a burden, having no reason to live, feeling trapped, if any of that talk is happening, we have to be concerned. Anything resembling, I just don't want to be here anymore, or I don't want to live anymore, it needs to be a ding, 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 right? And it's better, even if they are being manipulative of what parents are fearful of, it's better to assume they really mean it. Because if they're trying to gain attention in this negative way, it's better to assume that so that the conversation can be engaged. And then you'll find out why did they even say that. Behavior, of course, right, is the next level of realizing that you have to intervene, especially when it's related to a huge event or a big loss or a change. For someone who can't manage that kind of level of change or loss can increase the risk. But many of us who experience so much difficulty in life, we didn't respond with, oh, I just don't want to live anymore. So sometimes we cannot understand the teen and children's level of reaction to difficult changes because we took it, we just have to struggle and live through it and we'll come out in successfully. So So we don't have that mindset of what they're going through. Children these days, even if they don't get what they want, they'll automatically, well, you know what? I'm just gonna die. Right? And you're just like, what? From that? But for them, it is a huge deal, right? And so this is what we're facing regarding what they think is important to the point of life and death. So that's another talk for another day. But in terms of what behaviors to watch out for regarding the behavior of suicidality, especially use or misuse of substances, alcohol, marijuana, crack cocaine, any substances, if there's an increased use of it, looking for a way to end their life, such as online research and methods. If you're finding that out, they're being withdrawing, isolating themselves socially from friends and family. Visiting or calling people to say goodbye, that's definitely something uh, to be aware of. Giving away prized possessions or acting very recklessly. And then symptoms like depression, aggression, fatigue, and sleeping too little or too much. All of these changes, along with the talk, we have to act upon that and get them help quite quickly. And then the third area is mood. In the mood, depression is the most common related to suicide. 90% of all completed suicides, 90%, are due to the individual having had untreated mental illness. And then amongst that, depression is the top one. If they had received treatment for depression, it wouldn't have gone all the way to the suicidality or attempt. So depression, anxiety, loss of interest, irritability, it could indicate that they're at higher risk of suicide, especially of untreated. In my practice and all of the years, I take it very seriously and I'm trying to engage for them to get treatment, whether it's just therapy and medication, because the more quickly we settle down the depressive episode, then we are reducing the risk, right? So for cardiology and for other medical specialties, their life and death risk of their clients, their patients, is a physical, right? So for cardiology, they treat the atherosclerosis and then the risks for myocardial infarction, right? They're trying to reduce the risk of a heart attack because that's the life and death risk. But in psychiatry, our only risk that we were trying to prevent or trying to lower is that someone would kill themselves or even homicide, even though that's much more rare. Right? So um, that's why we take every single, even though it's a mild level of mental illness, of all the different kinds of mental illnesses, to a major level or major severity. We take all of that seriously because mild can lead to major, right? It can lead to severe. Okay, our next slide is how to support, how can we support someone in the crisis right now, right? They're talking about it, they're having some behaviors. What can we do? First of all, is don't be afraid to ask about their suicidal feelings. Some people feel that we shouldn't ask because we might give them an idea to do it more. That is not true. Studies show, they even do studies, that asking about it is more of a safety factor, actually. And of course, the way your facial expression is going to matter when you ask, right? And all of these kind of gestures. Second one is if they are in danger, right? Don't leave them alone. Right? Of course, don't leave them alone, but also don't overreact. Right? So let's say your child, if it's your own child, they don't want to live, and okay, you know what? I'm gonna stay home today. Let's hang out. Let's talk all day. And even though they say, no, no, you don't have to. Well, I'm not really sure if you're really in danger, and I want your feelings to pass. And then they'll say, okay, right? Because they are really feeling unsafe. But you don't have to go to the bathroom with them and follow like two feet after them all the time, right? So there's a level of balance of how to be with them and not leave them alone. Another way is ask them if they want to talk, right? This is important because for teens, at any given moment, they may not, excuse me, they may not want to talk about it at that moment. Right? So asking them for permission, and I'm here to listen. Would you like to talk about it? Um, I just want to hear you out. Some would respond right away. Why? Why? What's making you feel that way? What's going on? Right? To really kind of almost trying to force them to talk about it. But this is more a very patient way, although that's very difficult because I would be very panicky too, right? Very patient way to show them that it's not alarming to you, although it is alarming, so that you can have them pause to think what's going on and why they're feeling that way and to share it with you. So that's what the environment that you're trying to create. Another one is to really tell them you care, right? Um, this is the part that's funny from from the previous lecture is assuming, we assume that they know that we care. And they do know, right? Our children, they do know we do care. But there is a power of sharing it out loud. So during a crisis, especially, to mention, I love you, I care about what's going on, right? And they should receive the confidence that you care, not about that they don't hurt themselves. That's a behavior, focus on the behavior, right? But that you care about them, their life. Because if they think that you care, that they act on something or not, then you're focusing on their behavior, right? But this section is telling them, you matter to me. The reason why I want you to stay alive is because you matter to me. I love you so much, and I care about what you're going through right now. I'm so sad. I can't take it away, but I want to learn about it. I want to be here. I want to do that. And I want to share with you there is hope, even though you don't feel that way. So that's the reason for that kind of sharing explicitly about how much you care. And the next one is encouraging them to see a mental health professional or sharing with them that it's okay that we get counseling. I can do it with you um, because I think we need to help each other about that. So how about we make an appointment together? So if you say that, they might feel weird. Because some parents tell me how they've kind of forced their child to come see me. But after they do come and sit and talk to me, they're willing. But it must have been a hurdle to like get them into the office. And so sometimes on that day, they may not be open to the idea, but you do have to consider that like maybe the next day if they're going to be safe that particular day. And then the last one, this is very important, is letting them know this is going to sound funny. It's okay to feel this way. So, what I'm trying to say, of course, it's not okay to have suicidal feelings because that's a risk that it will go to suicidal behavior and maybe they will take their life. But it's not a sin, or it's not they're bad children or bad people for feeling this way because they already feel bad to feel that way. I hope that makes sense. When they feel life is not worth living, uh, they already feel so weak or defective. But if we emphasize that is horrible, you shouldn't think that way, look at your life, you have everything, there's so many homeless people out there, how could you feel that way? You get 3 meals a day, you get good education. Like if you start talking like that, right, when they cannot even explain why they feel hopeless and helpless and worthless, right, then they will even feel worse, right? And they will feel so guilty to even feel this way. So we cannot put that fuel to the fire during a crisis, right? During a crisis. I just wanted to remind you, this is some of the things we can do, how to support them. Now, here's a scenario we can review today. Let's say somebody says, I want to die. Why should I go on? They mentioned it. This is the speech part. Once a suicidal comment is heard, or about their thoughts of dying, they confess those feelings and thoughts. As a parent or as a leader, because some of you are maybe leaders at church with young people, we can respond right away. Can you tell me more about that? Do you have a plan? Do you have a picture how you would maybe take your life? Do you feel safe to be alone? Can we leave you alone today? Are you sure you'll be safe from harming yourself until I see you again? And the reason why I say the word harming yourself, because sometimes it's a self-injurious behavior, like cutting, rather than like fully wanting to take their life. And then see what they say, right? That's the triaging that you can do. Now, if that person is able to contract for safety, that is a phrase that we use. Contract for safety means I promise, and then they are believable. Okay? But sometimes they don't sound believable. Yeah, yeah, I'm not gonna do it, I promise. And they want you to like go away, and you don't feel comfortable, you don't feel confident, then you have to keep asking the questions, right? Um, if it's not your child, then who can I contact that they can be beside you and watch you? Because you don't want to leave that situation without knowing that. Then you can alert the family member or trusted friend. This is for children and adults, right? That this individual needs to be observed and watched together. And if you don't believe that contract for safety, right? Especially, you know what, I don't want to talk anymore. Like they don't give you that confidence and they walk away, that's a good example, then you might have to call 911. You have to call 911, and because now they're about to drive off and you have no idea. You can call the closest kin, closest family member, and then say, you know what, because I'm the last one who talked to your loved one, I can offer to call 911 because I know which direction they drove off, or and that's okay to do. It is okay to do that, and we should do that, so that even if the police found them in the car, certain license number and all that, and the description of the person, they'll ask questions. I got a welfare check call that you don't want to live anymore. Like, what's going on right now? And then they will do their assessment at that spot to make sure that they are believable in their contract. Now, if somebody is actively suicidal, the word actively suicidal means they have a plan, no one can stop them, I'm going to do it, or they have something in their hand already. The gun is in their hand, or the weapon, or the bottle of pills, or the rope. Okay, you. It's like a very dangerous moment because a knife is in their hand or something is in their reach. Um, then that's the case where you call 911 as well. Okay? Provide the description and the closest physical location and address. Now, this is the part where it's very unclear. It's not safe to apprehend them yourself, and hold them down. That is not very safe. So you're just going to have to hope and pray that they stay in the same building or the same room as you. But if they do run off, some teenagers, they run off, we call that elopement, that you have to call 911 immediately. And I know your heart will be racing and it'll be panicky, but that is the quickest way. And you explain the situation. I don't know where he ran off to, but this is my address. This is what he's wearing. This is how tall he is. And please, someone go out there. It's very, very dangerous situation. So that's what you would do. And then, of course, afterwards, you would follow up, right? If it's not your child, but it's a family friend or it's a mentee at church, following up after the hospitalization or after the appointment is also very, very supportive so that you can continue to encourage them to get the help. Now, what about this situation? What if someone was suicidal, but there is no active gesture, there is no plan or intent, but they feel that way, and you have no idea it's going to advance to having a plan. But they're very bombarded by the thoughts of, I'm trying not to think about it. I'm trying not to, but I just don't feel like I have hope to face tomorrow, right? It's kind of like that middle ground. We don't know what to do, but they're not grabbing the knife or the rope or they're not running away. And you're sitting there like, well, can I go to work or not? Or can I leave you alone or not? You're not really sure. You don't have to put that pressure on yourself. There is a mobile crisis intervention unit, and I'm going to show you the whole list right here. And then these slides can be given to you. I think Tammy can give them to you because these phone numbers are very, excuse me, very, very helpful. In each county, Orange County, LA County, these different counties have a crisis mobile response team. What that is kind of like a mental health ambulance, although they're not very quick. Okay, when you call them, they don't come to you very quickly. But you can say, I'm with someone who is um, saying they are feeling suicidal, but they're not actively with a plan, but I don't know how safe that person can be and be left alone. Can someone come and evaluate? And when they do, that team comes, right? That team comes and evaluates the individual, asks a lot of questions, and then they can decide, yes, I think you really should go to the hospital right now and be safer in the hospital, even though it's a locked unit and it might be involuntary hold, but usually it's only less than 72 hours, and then they get discharged. But while in the hospital, they get all of the referrals and all of these um, support systems to be taken place after the discharge, right? Now, what's really scary sometimes about this team, sometimes they have to bring the police with them, not to arrest the patient, potential patient, but because the response team members, like these different CAD, PMRT, these teams, they're not authorized to do an involuntary hold. Involuntary hold is a legal procedure where, against someone's um, will, to be placed in the psychiatric hospital unit. So that is called a hold, meaning that's a particular order. And only the police and certain authorized, I can't even do it, but only the police can write that kind of order. So when for example, Orange County, when the CAT team comes, they say, yes, this person needs to go to a hospital. And many times they were given the choice, do you want to go in voluntarily or involuntarily? But voluntary, a lot of people don't go voluntarily. And sometimes they'll go voluntarily, but they walk out the next day. Right? So majority of the suicidal clients and patients have to be placed on the hold involuntarily to ensure that they are staying in that locked unit for a few days. For children, the reason why that is also involuntary many times is because parents are not in their right minds. I mean, they're very emotional, and so it's okay to be that way. So they sometimes are wishy-washy, ambivalent about keep my child in the hospital or not. Because sometimes what I hear is they allow them to go to the hospital. After the first day, the child is like, I'm not suicidal anymore, but I hate being here. Take me home. Take me home. But then the parents are so soft-hearted, but they can't take them out. But if it was voluntary, they would say, okay, let's go home. But what if clinically, what if their condition was in a situation that they shouldn't be taken right then and there? Only the doctor and the team has that judgment clinically when they're ready to go home. Okay, so kind of explain that procedure. I just wanted to share a few more slides about resources. In the back, we do have business cards and information of resources of Fully Health Clinic, Oak Health Center. The difference is Fully Health Clinic is a Christian-based clinic that was established by Oak Health Foundation, but this is cash only out of network, even though there are opportunities for sliding scale discounts according to household income. But you would be sure that a therapist or a prescriber, someone who gives medication management, is a believer, is a Christian. Oak Health Center, Dr. Mead and I also have founded Oak Health Center, and that is a clinic that accepts insurances, quite a few different insurances, unfortunately, except Medicare, Medi-Cal. So if you have that kind of commercial insurance, HMO or PPO, then somebody in the Oak Health Center can provide care. They may or may not be Christian, but the front desk has a list in case you really, really want a Christian. But when it comes to crisis intervention, it should just be anybody to immediately start some care. The last one, I know the small letters, psychologytoday.com and betterhelp.com. These are just examples of online search engines in case you can't come to anywhere physically, or you'd rather just do only virtually, or your child says, I'm just going to do virtually. Although Fully Health and Oak Health Center has virtual opportunities, you can search for the type of therapist and where they're at, kind of services they provide through the search engines. Now, the last slide I want to encourage is that this is a spiritual battle. And a mental health crisis is probably the climax of a mental battle that's being engaged in by the enemy. The enemy wants to steal, kill, and destroy. Right? Definitely wants to eradicate hope, right? Destroy the peace, and make someone believe life is not worth living. Makes them believe that whatever problem they're going through will never go away, it will never have meaning. And his number one strategy is death. That's why the wages of sin is death. And he wants young people to die before they can experience the love and grace of Jesus Christ as their Savior, before they can experience being reaching their potential of what God has for them on earth before they go to heaven. So that's why I do believe suicidal feelings can happen even in a believer. The cognitive distortion and the irrational thinking that could happen in any human being, even though their soul is saved, right? At a split moment, they can have incorrect thoughts, and the devil can try to put fuel to the fire about that. That's why we have to be in prayer as we help them in this crisis intervention. Be in prayer and realize, Jesus, my son, my daughter, my niece, nephew, my student, their life is in your hands, but teach me what to do to preserve, physically preserve, that they don't harm themselves right now. And then you can use the authority you have in Jesus to cast out in the name of Jesus whatever demons that are like misleading them, right? I just want to make sure that we are representing where we have to do everything comprehensively, not just pray. Because if you just pray and then they go out and they do kill themselves, you're like, oh, I thought my prayer was going to be strong enough, right? I'm not saying that it's not strong enough, but physiologically, right, we have to intervene at the same time as well, psychologically, relationally. So we have to do all of it. And as we're doing all of it, that we trust in the Spirit to intervene also. So now we're going to have Q&A here. So thank you.